Sir, we are already live. So with your due permission, shall we start the session?
Yes, please.
A very good evening to all of you present on today's session. I am Nishita from IGCP Group. Welcome everyone on Allergic Asthma Management. And to present this topic, we have with us none other than Honorable Dr. Vijay Bharat, sir. Let me share experience of sir. Sir has done MBBS, MD. Sir is also consultant allergist, pediatric pulmonologist, and clinical immunologist. Sir is consultant at Sai Allergy Asthma Eye Hospital and Shayadri Hospital, Inamdar Multi-Speciality Hospital. And to share about today's session, managing allergic asthma is crucial for individuals with this condition to control their symptoms, reduce the frequency and severity of asthma attacks, and improve their overall quality of life. The management of allergic asthma involves a comprehensive approach that combines various strategies, including allergen avoidance, medication, and lifestyle modification. Now, without wasting any more time, I would like to hand over the session to Dr. Bharat. Sir, over to you. Please proceed.
Thank you for the kind introduction. Thank you, IGCP, for giving the opportunity to discuss this very important disease, because as the scenario has changed and how the diabetes, blood pressure problems, heart attacks and all, at least the people are aware about these things. But still, most of the population, as I remember, since last 34 years, I'm seeing that there is a lot of stigma about asthma into the community. Because what they feel is that people, once they have an asthma, they feel lifelong they have to be on that. A lot of misconceptions still, like inhalers are the addictive. Rather than that, we should have something home remedies. And the big misconception is that they feel it is a lower immunity. But it's a hypersensitivity. So such a simple things also, the people have so many misconceptions. And besides that, whatever the disease modifying therapy available worldwide, and that are used as a specific target therapies, that awareness into the community should be improved by having a uniformity amongst our colleagues and to treat it a better way to improve the quality of life of the patients. So if you see still the epidemiology, it's important emerging disease in India. Like even any diseases, most of the time, the records are maintained in a very big hospitals. The smaller nursing homes into the rural areas. And as I mentioned already, people don't want to be labeled as asthma, specifically children's, even the adolescents, young adults, they don't want to get labeled as an asthma. So they don't label that. And so that records, maybe I feel personally, these cases must be 5 times whatever in an Indian scenario the records are there, or medical records. So worldwide, the asthma has already increased. And specifically in India also, we have seen a lot of shift in that. And many cases are seen, not only in the urban also, still into the rural areas because of the overuse pesticides, because of the firewood burning, the bio-waste burning. It has again increased into the women's and in children's. Now, allergy is one of the number one chronic disease amongst children. Amongst that, childhood asthma is number one chronic disease. And out of 10 children with asthma, 9 always have an underlying allergy. So most of the children may overcome the symptoms of asthma, but later on, inside the body, without any obvious symptoms, the minimal persistent inflammation, the newer sensitivity to the pollens and other allergens, it goes on increasing. And when the patient in the adulthood has asthma, it is more severe. It does not respond that effectively whatever it used to be. So even allergy, asthma, COPD overlap syndrome is there. It is very well documented now. And there are a lot of chronic respiratory diseases. And as COPD is the second causing disease in India. And even amongst the adults with asthma, 65 to 80% of the people have shown a sensitivity to allergens with skin prick test. So that's why today we are talking about the allergic asthma. It's very common. Even many of the patients don't know the asthma underlying allergy is there. They always feel it is something different disease. But allergens also very play an important role into that, and specifically allergy. So we have to manage the allergy to improve the quality of life. So it's a basically heterogeneous disease. What it doesn't mean? Because primarily genetic part is also there, along with environmental factors, the diet. And so when we manage the patient, we have to manage with the environmental control, lifestyle change, and as well as some diet control and some add-on therapies also or supportive therapies also. So diagnostic and therapeutic tools should be utilized very well because practically we have seen many of the patients, they are just given inhalers or nebulization and all, or any of them may be taking a Ayurvedic homeopathic treatment and all. But they're objectively, their lung function tests are not done. That should be done because even in spite of asymptomatic from above, 2014 only, there was a study done. 92% of the patients had a changes into the lungs when the objectively the lung function tests were done. Now we are seeing a lot of phenotypes, endotypes also. And that's why later on to have a severe asthma or out of severe asthma, having a cardiac problems, have comorbid conditions and leading to other poor quality of life, we should look for these recent guidelines, how these allergens, then TSLP, then these interleukins, how they have play into that and how these genotypes and phenotypes should be managed against that. So basically, it is a multifactorial genetics, how the diabetes blood pressure has increased the same way, allergy, asthma have already increased, and then add on these indoor and outdoor pollutants, diet, lifestyle, stress. Basically, it is a hypersensitivity, IG mediated response. And those children or adults which have already been sensitized to the allergens, or because of the some of the few one which have a pollutant triggered allergy, they will be triggered by the smoke, strong smells, AC, fan, ice cream, cold drinks. So most of the patients they feel like those are the primary things, but actually they are the irritants. Even there is a lot of cross reactivity amongst pollens and foods. So many of the people feel like after eating banana or citrus fruits and all, they get a problem. But actually, there is a cross reactivity. The primary allergens are dust mite, pollens, and all. That's called the oral pollen food allergy syndrome. And we have to remember that inflammation into the airways that should be managed. Airway means not only the just bronchi, but even from nose to sinuses to the throat. That inflammation also should be controlled because one airway, one disease is there. So many of the patients of asthma we have found they don't get control with the inhaler nebulizer. But when we manage the nose also properly, nasal mucosa inflammation is controlled, the sensitivity, whatever is happening from the nose, they have a very better recovery. So this was a doctor basically, 43 years old, with repeated cough, breathlessness since many years. She had been investigated in a very big hospital for all the bronchoscopy and all. Even she was referred from chest physicians to even rheumatologists, cancer specialists. And she was, investigated for the cancer also anything. But one of her son-in-law has a vegetable shop near my hospital. And sometimes on Sundays I used to go there. So he used to listen some of my phone calls. So he asked me, he said, what are you expert into that? I said, yeah, in allergy immunology. So she was brought to me. And when I examined her, she had a significant deviated nasal septum, turbinate hypertrophy and all, dark circles, Denny Morgan folds. And looking at her history, some of the other times she had eczema in her childhood. So we tested her, and then we started desensitizing along with the proper inhale corticosteroids to control the inflammation, nasal sprays and all. And she showed a very good response. After now 3 years, she's off inhaler. Sometimes occasionally she has some cold cough and all. So the environmental triggers, even some of them may have exercise-induced bronchitis or after playing and all, hyperventilation, pubertal changes or menopausal changes can have the problems. Then emotions, then indoor-outdoor pollutants, then comorbidities like GRD, obesity, these also can have a problem with that, or they can trigger it. So already the pre-existing airway inflammation is there. These triggers or irritants can increase that. So primarily the allergy symptoms we have to manage, and then add on whatever the factors are there. We have to guide to the patients about that also. So basically, it's a airflow constriction and hyperresponsiveness and causing a contractile response of the airways to a variety of stimuli. And here the mast cell activation is important. And then it may release the cytokines, inflammatory markers, histamine, and all those things, lymphokines. And depending on these mast cells, eosinophils, basophils are the most specific cells. Mast cells are most of the time. And some of the patients, eosinophilic variety also can be there. And this constriction, inflammation, which is reversible, should be managed in an early stage. Otherwise, then it may go into asthma COPD overlap syndrome in some of the cases, and that can be irreversible also. So if you see this, depending on the smooth muscle, the underlying mucosal epithelium, the glands, and the parenchyma, they can also be involved. And the mast cells are the very important into that. So if the child which has an atopic history in early stage, in the family history also that, even if they have severe food allergies, sensitization if it is more in an early stage, and comorbidities like 90% of the children have rhinitis, may not have a sneezing or rhinorrhea, but there, if you carefully examine them, they always have a turbinate or posterior pharyngeal hyperplasia, dark circles, the Denny Morgan folds, the Darien line on the nose at the junction of hard and soft palate, long eyelashes, cervical lymphadenopathy. We should look at these things. And then any of the passive exposure to the smoking, pollutants, or viral infections. Nowadays, many children are sent in an early stage to the nurseries and all. So it's a viral syndrome also, repeated viral infections also. And again, it is going hand in hand because the Th2 inflammation, because of the allergy increases, it suppresses the Th1. And that's why the children have a secondary infection. And most of the children are blamed for the viral infections. And we have to remember that this is a progressive disease. So even the eczema, most of the children, they overcome the eczema. Some of the children with the GRD or repeated colics or stomach upsets, they may overcome that. But later on, may have a cold, postnasal dribbling, throat problems, initially seasonal cough or something. Then it leads to asthma and all. And even after managing the children with asthma properly with inhalers or somebody takes Ayurvedic or homeopathic or something, but later on they may go into ocular allergies with VKCs, or then they may go into eczema. So there is a variation also in few of the patients. Some of the patient may start with asthma rhinitis, some of the patient may start with eczema, food allergies. So it all depends on patient to patient. So again, these are the epithelial findings. I will not go into the details, but if we don't treat it properly, then the remodeling and the structural changes will have a lot of problems. And focus on the allergen source is very important. So according to that, suppose the dust mites are there. So in the deep pockets of the bed, sofas, curtains, into the deep pockets of the car cushions. Practically in Pune, we have found all these studies. We took a brushings from that. We took a dust mites and we examined it. Then pet furs, then pigeon feathers, 17 types of dust mites are there. So Indian Blomia is important into that. Then cockroaches and all, they are everywhere. They come in the night and go away. So they're droppings and dried feathers. Then pests, molds, they are into the deep, somewhere under the basin or bathrooms. In school bathrooms, we found significantly. My 65 children with asthma, actually we did a study and we took a brushing and we found these molds. They come with the vegetable fruits into the deep freeze as well as whatever the bags, the vegetable and fruits are carried. Along with that, it may be there to the deep pockets of the kitchens. And the pollens can be traveled on the hairs, on the clothes. Even the animal danders can travel around 14 to 15 kilometers. Pollens can travel 60 to 130 kilometers. So clinically, always ask these histories, ask for any of the add-on like tobacco smoke, like we have a misery or after burning the tobacco they use in the morning. So something is there, and if passive smoking can be up to 2 to 3 hours, even if the parents or grandparents smoke outside and come in home. So these things are there, and very few patients have an actual food allergy. Then overuse sanitizers at home, perfumes. These also we should always ask. Then if you look at the asthmatic epithelium, how different type of this dysregulation is there, mucus hypersecretion, then disrupted TJ junctions, access of the bacteria, then that's why secondary. And these interleukins have a very big role. We have actually done the studies in Pune, and we found the interleukins, how they are positive for that. So this is a 47 years. Mr. Khan from Dubai had been to Pune. His sister-in-law is a doctor in one of the Inamda hospital. And he was suggested bronchoscopy after all the investigations, nebulizations and all. But he was reluctant for that. So he said, no, I don't want to go for the invasive procedure. So that's why he was referred to us. And then we found significant indoor molds because most of the time they are in air conditioner over there. Dust mites were very significant. And we guided him what type of dust mite proof coverings, then how the filters should be cleaned of the ACs. And then gradually we withdrawn from triple drug combination to Foracort 400, and he was much better. Only thing is, in between, occasionally he is coughing now, but his quality of life has improved. 80 to 90% improvement in his day-to-day nighttime coughs and all has stopped because he's still smoking in between. So again, while rule out the comorbidities, any of the NSAIDs aspirin into the adults, any, as I mentioned, exercise triggered. Even there are some cases like where there is a food-induced exercise triggered urticaria, asthma, anaphylaxis. So we have to see that also, but very few patients. Most of the time, these are the allergens and all they are. So symptoms also, again, then see for all these. So always whatever have been told for us, observe the patient, listen carefully, auscultate, palpate. These has to be, we should not miss that. Then depending on that, assess the patient of the severity of that. And if it is required, some of the exposure, the chest X-ray should be there. Then any of the acute viral infection, if it is there, it may lead to the problem. Because recently I remember 137 years woman in Inamda hospital. She had a 21 years allergic asthma, a seasonal one. And this time she had a significant flu infection. And it was not picked up by the practitioner. And she developed a pneumonia, then secondary infection, pleural effusion, empyema, required surgery. 3 months she was in the hospital. Out of that, 1.5 to 2 months in the ICU. So these also should not be missed, and we have to see that. Now, epithelial barrier damage, even the skin IgA sensitization happens. Now there are latest findings that the children in the early childhood, they should be managed very well about the skin. The skin cutaneous sensitivity starts when the child is roaming around the mother or grandparents, and these grain dusts, then food dust, the food exposed to that, the sensitization happens from there. And then it may have a food allergies like colic spasm, GRD. Then the newer sensitivity to the dust mites and pollens increase. And later on, they go into multiple sensitivities and severe inflammation leading to these inflammatory markers like interleukins. And then symptoms can be there. So if you see the aeroallergens are the most common allergens. Even recently, European Academy, 16,800 chronic respiratory diseases, asthma, obstructive sleep apnea, and chronic obstructive pulmonary disease. We presented the data. Around 80 to 90% of the patients had actually air allergens. And most of the when the questionnaires were taken from the patient in the first visit, they were blaming the food or AC or ice cream or something. So if you see the dust mites, 80%, pollens 20 to 25%, mold 7 to 10%, insects 10 to 20%, animal dander 5%. So insect droppings and dried feather also is a very important allergen in India. And we have to consider always this. Like childhood asthma may overcome, but later on they may go into elevated nasal septum, sinusitis, adult asthma, chronic respiratory disease. So this was a child, 5 years, referred from Jahangir Hospital by the pediatric intensivist. Some 1.5 years, the child had anaphylaxis with a oral food allergy significant, like the peanut butter was given. They were thought it is a peanut which is causing anaphylaxis, but actually it was a dust mite contamination of the peanut butter. You can see the long eyelashes significantly. And the child now was referred because repeatedly cough, cold, and the repeated infections were there. So we investigated and dust mite sensitivity was significant. So evaluate the patient. If the child 90% may show the skin prick test positivity, even the now component resolved diagnosis is available. Suppose a smaller child and the skin is also involved. Well, sometimes some of the children can have a two system involvement also. The skin is also involved in the asthma. So there we can do this component resolved diagnosis where around 120 allergens with the microRNA assay method can be analyzed. But gold standard is the skin prick test. Methacholine challenge test and all we are not doing in a routine practice. Very few selective patients in a big setup can be done. And even therapeutically also, if you see, if these patients are given a proper salbutamol nebulization, or some of the patients may require newer molecules like formoterol nebulization and all with severe asthma, they show an immediate some response. So that is a reversible bronchoconstriction. So then biomarkers are very important. Nowadays, even some of the patients, like 5 to 8% of the children and adults also around 8 to 12%, where the severe asthma is there. Then the eosinophil count, then serum total Ig. Routinely, these are not important. Just we have to rule out any other things. So for that ruling out, we should do it. But most important is the standardized skin allergy testing. And then to monitor the patients, we should go for the spirometry, smaller children, phenos, even oscillometry is now available about 2 years. And while managing these patients, to build up a confidence into the patient, always give a good nebulization, inhalers, nasal sprays, if required, leukotriene receptor antagonist, to control the inflammation faster. If required, steroids, depending on the patients, 4 to 5 days also oral steroids can be given, not longer, or repeated steroids should not be given. And it requires a multidisciplinary proper approach, and the long-term reduction of the airway inflammation is important and improve the quality of life. So step-up therapies are there. So now GINA 2023 also, it has been mentioned. So I will not go into the usual treatment of this, but I will say like inhaled nasal steroids, inhalers are the best one because they directly act locally and they are excellent through that. And some of the severe patients, if they don't respond to the very high dose of inhaled corticosteroids, then rather than oral steroids, the biologics like omalizumab, dapirolizumab, benralizumab, dupilumab, they should be used rather than that. And very few patients have a very significant hypersensitivity. They may require a low dose oral corticosteroids also. So while controlling these patients, we can use a safer molecules like leukotriene receptor antagonists like montelukast and all. And nowadays, even the NS in acivrophilic, because many of the patients, because of the chronic inflammation, even the cilia are affected. And that mucociliary clearance is not there. That's why N-acetylcysteine and acivrophilic combinations and all are much useful. And those patients with moderate to severe asthma, even after the allergy testing, allergen avoidance measures are educated and required allergen immunotherapy, not in a severe asthma. Then they don't have much show results. When children with asthma show very good response to immunotherapy. Immunotherapy basically it's a desensitization or allergy vaccine shots, we call it. Even now they are available in a sublingual, oral, as well as injectable shots. Injectable shots are above 8 years. Above 2 years, the sublingual immunotherapy can be very well given. So acute exacerbations will not go into the details because most of us are managed according to our own experiences. And then depending on that, we put the patients on the inhaled corticosteroids. But as I mentioned, one area, one disease, always look for the nasal mucosa, and that should be managed with the proper nasal wash with the nasal mist. Douchings are also available in the above 12 years. The bottles for the nasal wash are also. And always look for the any of the differential diagnosis of comorbid conditions, because obstructive sleep apnea, GRDs, they trigger a lot. And asthma COPD overlap syndrome should not be missed. So the spirometry and other these oscillometries and all, they can pick up this overlapping also. But allergy diagnosis has to be with the proper standardized skin allergy test with the selected one depending on the exposure. And in some of the patients, now multiplex assay methods are also available with the artificial intelligence has been used. But again, some of the Indian allergens, they may not have it, some of the Indian pollens. Some of the patients, after doing that also, we have to do the skin prick test, because whatever the positive results are there, and those allergens, they are not into this component result diagnosis. We have to test for the skin prick test, because once we suppose we want to give a desensitization, ideally medical legal purpose also skin prick test should be done. And then only we can, because in skin prick test, the mast cell bound IG is picked up. So that has more value, because circulating IG may have a false positive and false negative reactions. So what does it mean? That suppose a patient has a very high G, and if you do the blood allergy test, so there will be multiple allergen positivity. And suppose the serum total IG is low in that patient. So those patients may not show a good sensitivity to the blood allergy test. So that's why. But the skin prick test has a very good predictivity. If it is negative, most of the time in a standardized allergens, it's negative. Even the blood test sensitivity has been shown. But the skin prick test, if it is negative, it has a very good accuracy with that. So depending on that, we have to always see the history, the allergen exposures, then exercise or other tobacco smoke, or even suppose somewhere there is a sugar factory or some factories are there, depending on that also. And then clinical examination, and then diagnose the patients with the spirometry, pheno, oscillometry. Pheno and all, they are in a very few patients, which is a eosinophilic variety. But spirometry and oscillometry are routinely done now. Only in Indian scenario, the children's oscillometry readings we have to analyze. Adult data is much better now. So again, then modified asthma predictive index also, the major and minor criteria depending on that. The pediatric respiratory assessment measures and all, they are standard everywhere. We can have it. We can download from anywhere. And then again, differential diagnosis also should not be, because some of the patient, if they are overlapping of that, they may get a complication and they may have problems also. So again, non-invasive markers of like pheno and all can be done refractive or severe allergen. So skin prick test is the best one, and it basically sensitivity of that patient and the clinical correlation also can be very well done, and even the phenotypes also can be measured with the, if required, eosinophil and IG levels, and ready to be interpreted. I mean, within 40 minutes, we can discuss with the patient, and the specific IG, the standardized skin prick test, and with the clinical correlation, we can guide the patient about what type of. And then some of the patients, they may have a upper airway involvement also. So that also, if it is significant, like blockers, no, post-nasal dribbling, those should also be managed. And then other, like suppose the child infantile period, there can be vascular ring, laryngotracheal malaise and all that should be. And the toddlers and all, foreign body and all should not also be missed. And depending on that, if it is a resistant or refractory asthma, then bronchoscopy also is advised. There can be ring, or there can be some hemangioma at the vocal cord that way. So always look after all these things. Right? Definitely the asthma has increased. Allergic asthma is also very common. But as a doctor, we have to always see for, as a completely patient, never jump to the A. So always think about the uncommon things also, rule out those also. So that way we have to manage with this. So how we should have an approach? As we discuss about that, clinical assessment, then objective also, then trial of therapy, how the response is there, then continue the therapy. Suppose the patient doesn't respond, again, see for the review asthma probability, any of the other like comorbid conditions or a differential diagnosis also we should do that. Bronchial provocation test in a very specific cases and in a very good setup. And emergency management should also be available. Complications are many. Even quality of life is very poor. If the child is suffering, whole family suffers. Office, school, work, absenteeism, emergency, the confidence of the patient, psychological effects also. Secondary pneumonias, asthma, COPD overlap syndrome, even severe asthma in adults will have a 30% patients have a cardiac problems. And even the biomarkers, as I discussed, like the interleukins and all, in our clinic, these patients we analyze and significantly the Th2 inflammation and these IL-3, IL-4, IL-7, IL-13, IL-33, where definitely increase the and those patients when we manage with the desensitization and safer medications and all, the antibody formation against the IL-3 was also found. So actually, these biomarkers, actually, after the COVID, at least people are aware about IL-6 and all. But in our practice also, later on, once the cost will come down, we can use it that. Why it has to be done? Because some of the patients which have a significant severe asthma, there, the omalizumab, mepolizumab, benralizumab, dupilumab, now they are available. Even in Pune, I'm doing a study for omalizumab in asthma, itikimab in severe asthma, COPD patients also. So these target treatments are better, those patients which require a repeated steroids. So while managing these patients, first is the allergen control, environmental control, whatever the exposure to the strong smells or insecticides or passive smoking and all, that also should be there. And then depending on that, HEPA filter vacuum cleaning, then if the pets are there, they should not be on the bed and all, they should be away from that. So these things also should be, and depending on winter is there, if there is a smog, these pollutants and the pollens are trapped down. So the mask should be used. If the children are going on the bike or the rickshaws, they are at the lower level, they should also use masks and all. And those patients, these allergen immunotherapy are very specific. Basically, these purified allergens are administered to the patients in a very small dose, like 1:1 lakh dilution or something, then 50,000, then 25,000, then 10,000, slowly up to 100 and all. We can increase depending on the age. And sublingual immunotherapy in 2013 also in Hyderabad, when World Allergy Organization had a meet, they have found both are very well efficacious. Even the subcutaneous and sublingual agreement, house dust mite is a common allergen, pollens and all. They have also shown very good results with that. In my practice, I am using very well sublingual immunotherapy, and most of the patients we have shown a very good results. And we have to always educate to the people that it's a multifactorial disease, and the environmental control, diet, and lifestyle is in our hands. And depending on the pollutant and which exposure, the patient should be guided about that. The allergen immunotherapy is to stop the newer sensitivities, further inflammation, and further complications. But definitely, if you give it properly, it reduces the symptoms also. Suppose a child who will going to require for 3 to 4 years to have a control. With the immunotherapy, the children have a better efficacy within 9 months to 1.5 years that way. But it is not a magic wand. Like the immunotherapy is given and the next day the patient is better. So that awareness also should be brought together. Because I have seen many of the doctors when they refer the patient, even doctors also don't know. So that what they feel is that once the testing of so much costly and the immunotherapy is given, the next within 2 to 3 months the patient should show a response. It is not that way. Immunotherapy, so it's simple to understand. Suppose some wall is there and the leakage is happening from somebody's bathroom and all. To find out the leakages means the allergy testing. And to stop the leakage means immunotherapy. And whatever the damages on the wall has happened. So the same way, whatever the inflammation and hypersensitivity in the nose and sinus and the airways is there, to control that inflammation and to bring the hypersensitivity to the normal sensitivity, some medications like Montelukast, as well as nasal spray, inhalers, steroids and all has to be given for 1 season at least, means 1 to 1.5 years and all. So all the three things has to be managed. Even the simple precautions also has to be taken, like a diabetes. So this is a simplified approach, and according to that, we have to guide the patients. And long-term management of the improvement to the lung function and to stop the remodeling and the complications. Even always, again, repeatedly assess the patients for the techniques also. Like nasal sprays, wrong administration is not useful. So the lateral wall, the turbinates, it should be there. There is no need to in a deep also to sniff inside. It just tap it and then nasal wash, then inhale steroids also. most of the patients, they can't inhale properly, so it is stuck up to the throat. So always assess with the spacer or device, check it, because that is very important before labeling it as a severe asthma. So inhaled nasal sprays and corticosteroids have a very efficacy, very few side effects. I mean, I haven't found any side effects. If they're very high steroids, some children may show a growth problem and all, but once we stop it, again they have a recovery into that also. Combinations of the therapies now, 2 drug, 3 drug combinations are available. Then the LTR is like montelukast are also very safe. Very few patients show it. Depending on the effects and the improvement in the quality of life, very few side effects are there. So even I will always say to the patients that it is more safer than whatever they are eating ice cream and oily things and so many spices and all. So even the llamas and all about 12 years have been very well used in some of the refractory cases. Type 2 inflammation, the Th2 inflammation is very important, and these biomarkers. So now while treating this severe asthma, the 2023 guidelines also, we have to think about this. So some of the patients, then absolute eosinophil count, pheno test, sputum eosinophils, then oscillometries can also be done even about 2 years. And depending on the, we can adjust the dose of ICS. So some of the patients, even they feel like they are controlled, but the studies have shown 80 to 90% of the patients, objectively, when the tests are done, they are not much controlled. So there, if you do these tests, we can guide the patient to continue the inhalation therapy, or suppose underlying inflammation is significant from patient's perspective, symptom-wise, they may be better, but we have to control that inflammation for a longer period with the inhaled corticosteroids. And again, review the response and implications of the treatment also should be analyzed. So this is a very crowded slide, but in short, we have to always look for the comorbidities also, symptom control also, objectively also, and the adherence should be there. See, practically don't give inhaler and say take it for 6 months. Always I say what I do in my practice is that always call the patient monthly, because I have seen if the patient is having a coordination with us, even it may be in a USA or Dubai patients and all. I have many patients from outside. I always do the online consultation every month because it gives a confidence to the patient also. There is a dropout rate is also reduced. And depending on the season also, like pollen season or pollutants, like during the winter, we have to guide the patients some precautions. Otherwise, then they lose the confidence and they go to the other doctors and all. So to have that also, always tell the patient that every month you have to always in contact with us, whatever the online or offline. So if there is no evidence of type 2 inflammation, then go for the like llamas and even you have to go for the HRCT bronchoscopy and all. This should not also be, or any ciliary kinesias and all. Very few patients, like even look for the other cystic fibrosis and all. So again, non-biologic options, if the patient is not affordable or the high cost is there, the only thing is that the biologics now are covered into the insurance also. If you don't know, then they are covered in the insurance and most of the patients, they get it. So depending on that, and if the comorbidity is there, like even the ABPA is also increased, allergic bronchopulmonary aspergillosis and all. So depending on that, we have to treat that. So nasal polyps is significant. Obstructive sleep apnea, that also should be managed properly. And some of the diet habit also. Some of the patients get a significant trigger by the spices or cross-reactivity of the foods and all. So depending on that, we have to assess and then to treat the patients. So biologic therapies, as I mentioned, these are available now in India, and while the patient may not show a good response, and if you add the or add-on therapies and still the patient doesn't respond, do not stop the ICS, continue that, because some of the patients may take some time and they may respond afterwards also. So continue the ICS therapy. And patient care is important. It's just not symptoms, the whole patient care. So depending on that, always educate the people that it's like a diabetes and blood pressure. And so that they have to take some simple precautions, like still the people are dusting at home. So these pollens, they come through the windows and doors and they are falling into the house. They are again into the air for 2 to 3 hours. So even if the pets are there at house, their pet danders, their hairs, furs, and in that again the dust mites are contaminated, pigeon feathers. So these simple things also should be maintained and we should educate. Now, today's talk is allergic asthma. So whatever the advertisers are done in the newspapers and so many labs they claim about the accurate results and all. It's not that way. Still, the gold standard is the skin prick test. So I want to highlight on that. And 75 to 85% of the patients show very good positive skin test in these patients. And allergens have shown a very good evidence A in managing the asthmas. Even 2017, the Indian Allergy Asthma Guidelines also. You can see how the allergy focused medical history diagnosed by the specific IgE test and allergen avoidance. There 3 days in Bangalore, there was a lot of discussions among the allergists. I was also part of it. And you can see all these on Indian college to so many guidelines are there. Even 2017 guidelines, I was as a faculty review author, Environmental Committee of American Academy. I am there and last 4 years I was working with the World Allergy Organization Allergy Prevention Committee and the BCSAI. In April 2023 only, we published that paper. And so basically, immunotherapy is the only disease modifying therapy besides all the leukotriene receptor antagonists, biologics, and all. The environmental control and the immunotherapy can definitely have a very good role to prevent the further sensitivities. And after the withdrawal of the immunotherapy, also 25 to 38 years, the patient has shown a very good results. Very few patients may develop a newer sensitivities and all there. And you can see like how the allergen immunotherapy forms the IgG4, IgG1 antibodies, IgA mucosal regulation for these allergic diseases. Not only the asthma, even rhinitis, severe rhinoconjunctivitis. Now, besides asthma, rhinoconjunctivitis is a very big problem. Now, since 2017, it has been found it is always not only rhinitis, it's a conjunctivitis. So many people go on rubbing the eyes and all, then keratoconus, dimple cell deficits, repeated eye steroids causing us cataract and glaucoma and fixed optic atrophy. So rather than that, these also should be taken care seriously. And very few patients have a contradiction, specifically severe asthma. If the FE1 is less than 70%, don't start the immunotherapy, wait for that, control the inflammation, and then go for that. If the patient is before pregnancy on the immunotherapy, you can continue it. Very severe atopic eczema and all, wait, control the inflammation, and a very significant cardiovascular disease. But sublingual immunotherapy is very safe. I'm using in those conditions also. And the aim is that what we should expect efficacy over the symptomatic medication, early onset of efficacy, sustained and increasing results, long-term benefits, prevention of the newer sensitivities, prevention of the asthma in case of severe rhinosinusitis, polyps, sinusitis, rhinoconjunctivitis, reduction of the steroids and cost effectiveness for the symptomatic treatment. But there are studies done with these patients which require repeated visits to the doctor and later on again having a David and nasal septum, obstructive sleep apnea, adult asthma, chronic respiratory disease. The effectiveness and the cost is also very less if you use as early as possible whenever indicated. So summarizing, even 90% of the children have allergic asthma. Adults also 65 to 80% have asthma. Allergic asthma, basically underlying allergy is there. Comorbidities should be analyzed. Then standard is the gold standard. Skin prick allergy test. Sensitivity and specificity test is very important. Standardized allergens should be utilized. And we can guide the patient with the integrated and holistic approach. So the simple precautions also should be there. Nasal hygiene should be much better. And some of the things like indoor-outdoor pollutants or passive smoking wherever they are staying. According to that, some care also should be taken. And steroid sparing biologics therapies and all should be utilized. Inhaled steroids, inhaled nasal steroids. Awareness among the community should be built up that these are the good addiction. They don't have any side effects, localized. Even they are much safer than whatever the people use, oily things and these things. So we should educate by coming together. Thanks a lot. Thank you.
Thank you so much, sir, for the wonderful presentation. Now, I would like to request all the participating doctors, if you have any queries regarding the session, please paste your queries in the comment section so that I can put forward it to sir. Meanwhile, sir, we already started getting the question. First question is strategy for prevention in this rainy season against chronic asthmatic in elderly patients.
Very good question. See, most of the time in the rainy season, the molds are very important. As I said, we did a study actually. So into the common public places, into the houses, or along the vegetable fruits also they can come in. So basically, we should use mopping rather than the dusting. Again, the dust mites, they increase into the beds and all. So they should be, whenever there is a sunlight, put that into the intense sunlight to reduce the dust mite quantity into the beds and all. So it helps. Again, secondary infection trigger these patients. So to control the inflammation, not to have a secondary infection, even traditional way, the pranayama and all, when there is a good aeration, the bacteria doesn't grow much. Then there are curcumin, colostrum like immunomodulators also. We should use it to avoid the secondary infections. So these things, even the proper nasal wash should be practiced. And if the patient has a significant history that during the rainy season, he always gets a trigger. So the cloudy weather, it has a more penetration of the pollens. The lightning, when the cloudy weather is there and lightning, these pollens, because of the breeze, they are sucked toward the clouds. There, they are broken in a very smaller pieces, and then again they are thrown in a very high speed and penetrate inside. So that way, the people during that time you should use a mask while going out and close the windows and all so that the pollen are much less. The nasal wash is also helpful, and using electric heaters and all to reduce that humidity also helps. So these simple measures also, and then preventive also. Nasal steroids can be used. The inhaled steroids also can be used as a preventive. Suppose there is a significant history into the patient, if they get a trigger during winter or any season, before 10 to 15 days before the season, they should be prepared and they should use that so that the inflammation is less and the exacerbation is also less.
Thank you so much, sir. Moving towards our next question, that is, in lifestyle management, what is most valuable key points to be signified?
Yes, lifestyle management means it starts from diet, environmental control, exercises, stress. And even like World Health Organization has said, health is not only physical, mental, social, but even it is a spiritual. So what does it mean? That is the mental stress should be reduced. So these are all important. So diet also should be healthy diet. But problem is that nowadays so many pesticides are used, and also we don't know what type of healthy diet we are having. So there are good supplements like zinc, vitamin D3 and all should be given. Even the person should be exposed to the natural sunlight after 10 to 12, in between 10 to 2, because the zenith angle has changed. So the vitamin D receptors get stimulated in this timing, not in the early morning. Then the breathing exercises definitely help to reduce the inflammation. And even because of the proper meditation and breathing exercises, the stress is reduced. Because practically we have seen many of the patients when they go to Darjeeling or some places, they took us from a list, like, suppose I go to this area, what will happen? But when they are happy and they go there, they don't have any problem. So inflammation is controlled because of the happiness, the inflammatory control hormones are secreted. Even during the COVID, I have seen my 37,000 pediatric asthma patients are there, significant one. But during the COVID lockdown, none of them had a problem because they were happy. They did not had a school. The parents were there. They were getting everything, whatever they want from home. The same way, otherwise it was that way. The adults had a lot of problems. They used to call me because they had a stress of losing the jobs and so many things. So what does it mean that the control on the inflammation is again on the reduction of the stress also. And then even the swimming is a very good breathing exercise in this asthma patients, even other allergies also. Nowadays, as I mentioned in between, the cutaneous sensitivity also happens. So the barrier is lost in these people. So they should also take care of the skin also. It also helps to these patients. So use a normal pH 5.5 soaps, then moisturizers also should be used in these patients. So these are the multiple approaches to that.
Thank you so much, sir. Moving towards our next question, doctor wants to know role of tiotropium in bronchial asthma.
Yes, it's very important. As I mentioned, in those patients, after increasing the inhaled corticosteroid, ICS, if they don't respond that well, then tiotropium, ipratropium are showing a very good results. I am doing studies in Pune also. about these combination therapies and all in these patients of refractory, which doesn't show a good response. These are most of the time, very few patients are there, but they are besides the Th2 inflammation. It's not a, it's a, that's why the llamas are required. So these are the llamas basically. And so about 12 years, they can be used very well in severe asthma. And even nowadays, glycopyrronium is also available in this severe asthma COPD patients. So that also can be used.
Thank you so much, sir. The next question is oral TT for chronic recurring asthma in case parents are not willing for spacer. Sir, I am posting the question also in the chat section. I don't want to be wrong.
Okay. Achha. Oral treatments for chronic recurring asthma in case parents not willing for spacer. See, basically, it's okay. I mean, we have a lot of oral treatments. Basically, oral steroids are there. They are used very frequently in Indian scenario, but they have a lot of side effects. So practically, the counseling is very important in these patients. We should educate them. It is a chronic respiratory disease. One season or one day treatment is not going to stop it. So we have to always tell them like the inhaled therapies are target therapies, minimum micron dose, oral tablets will go to the stomach, from there to liver, then metabolize, and some of the part is acting on the nose or airways. Rather than that, inhale are directly at the airways. And from there only remaining drug is outside. So the systemic absorption is less. So that counseling has to be, because their misconceptions have been filled in their mind over a period of many years. That is wrong. So we have to always have a uniformity. We have to say that repeatedly. Then some of the patients, add-on therapies like montelukast and all can be used, but not the oral steroids.
Thank you so much, sir. We are getting many questions. So second last question we are taking. We know already we are already over the time. The next question is from Dr. Naresh Grover, and doctor wants to know role of immunotherapy.
Yes, like in my 2-3 slides, I mentioned about that. As the child is small, and if we have asthma, the immunotherapy works very well, because before the remodeling and the changes are there in the airways, they show a very good response. Adults also, mild, persistent to moderate, persistent asthma, they show a very good results. But severe asthmatics may not show that much results, because already there are multiple factors into that, and they go into the different phenotypes. So there, not only immunotherapy, the biologics are also required. But definitely, immunotherapy is the future. The biologics and even some of the probiotics, they are the future in these treatments. So immunotherapy has a very good role in all the allergies, including asthma, rhinoconjunctivitis, rhinosinusitis, specific cases of eczema, specific cases of allergic urticarias and all. So immunotherapy has a very good role.
Thank you, sir. The last question of today's session, Dr. Reena Rathi has asked, which specialty is having higher sensitivity?
Can you please type the question, because I did not get?
Sure, sir. The question is, which specialty is having higher sensitivity? Sir, I am pasting the question in the chat section. You can see from there.
Achha, SPT, okay. Basically, skin prick test. See, there are standardized allergens and non-standardized allergens. Now, higher sensitivity is mostly dust mites, pollens, some of the patients, animal danders. In Pune, we found pigeon feather and dropping allergy, 37 to 40%. And again, as I mentioned, these droppings, they are been contaminated with some of the funguses. Aspergillus is very prominent for having allergy. And in the feathers, there are 17 types of dust mites. Amongst that, practically the blomia is available, like a skin prick test, routinely. And then some of the patients, the insect droppings and dried feathers, they are also having a sensitivity. So depending on that, and not only after the skin prick test, always clinically correlate also. That's very important because the only hyper sensitivity does not signify like that is the only allergen which is causing a problem. It is an integrated approach. Some of the patients have 3 to 4 sensitivities and they combined cause a problem. And some of the patients have only dust mite sensitivity significant and that triggers it. So depending on that, suppose a midnight, early morning symptoms are there, or after traveling to some place and where he is staying in the lodge or some damp like rural areas when they go, sometimes that houses are not cleaned and the beds were not used for a few months and all. The more dust mite contamination funguses are there. So depending on that, we have to always ask the history also.
Thank you so much, sir, for explaining all the questions elaborately. I hope all the questions of the audience doctors has been resolved. Thank you so much, everyone, for joining this session. And I again want to thank Dr. Vijay Bharat, sir, for giving his precious time and make this lecture a wonderful one. Thank you so much, sir. So with your permission, shall we conclude the session here for today?
Yes, thank you everyone for being here, asking me, and even increasing my knowledge also, and to give me a thoughts and stimulation. And thank you, IGCP also. Thank you.
Thank you so much, everyone. Thank you so much, sir. Good night, everyone.